Hello everyone, welcome to another episode of Next Saviours Essential Question Series, NEET PG 2025 Medicine Part 16. And today we are going to talk about the question where in the first half they are going to ask you to identify the disease, in the second half category in which the disease is lying, and based on that specific category they will be asking about the management. So basically what we are talking about is the management of the asthma and the identification of the category of the asthma. A 32-year-old woman present to the outpatient clinic with the complaints of frequent episodes of wheezing. Now, when you see the word wheezing, there is always a possibility that you are dealing with a question of the obstructive pulmonary disease. There is going to be a shortness of breath and the tightness of the chest over the last 3 months. So these are the first two lines of the question on the basis of which you have to identify that which type of the obstructive pulmonary disease that you have to proceed with. So how the history will be presented to you, like smoking, occupational or air pollutants will always be provided to you in case of COPD as far as trigger or the causative agent is concerned, while the allergens or the cold or the exercise or the irritants are provided to you in case of asthma. As far as other conditions are concerned, like chronic productive cough will always be present in case of a COPD, while in case of asthma, the cough is dry or often nocturnal. Sputum is concerned, it is common in case of COPD, it is rare in case of asthma. Wheezing is pronounced in asthma, while it is mild or rare in case of COPDs. The symptoms are concerned, it is persistent and progressive in case of COPD, while it is intermittent or episodic in case of asthma. So this is on the basis of which you have identified to some of the extent that possibly the patient is suffering from the asthmatic disorder. Now, if we further continue reading the question, that she reports that these symptoms occurs daily and often interfere with her activities. Now, particularly when climbing stairs or doing household chores. Now, she also experiences nighttime awakening due to breathlessness, which is around 3 to 4 times a week. She has been using her short acting beta 2 agonist inhaler frequently, which is the frequency is more than 4 times a week, but the relief is temporary. Now, basically, what they are asking now is that what is the type of the asthma the patient is suffering from. Now, you have to categorize it further. If you look at the key clinical findings, like in case of severe persistent asthma, the symptoms they appear throughout the day, while the frequency is relatively lesser in case of intermittent asthma, which is less than 2 days a week. If it is more than 2 days a week but not daily, it is mild category. But if the episodes are happening almost daily, it is moderate category. Then activities are extremely limited in case of severe, while there is no limitation of the activity in intermittent, minor limitation in case of mild, while some limitation in case of moderate. The nighttime awakenings is often provided to you in the question, and it is very commonly observed in case of severe persistent asthma, while the episodes are relatively lesser in moderate, while in case of mild the frequency goes on decreasing, like 3 to 4 times a month or less than 2 times a month in case of mild and intermittent respectively. The use of short acting beta 2 agonist inhalers, the frequency is usually required multiple times a day in case of severe. Daily it is required in case of moderate, more than 2 days a week, but not it is daily required in case of mild persistent asthma, but in case of intermittent asthma, it is less than 2 days a week requirement. So this is another part of the question on the basis of which you can think about that what is the category for that patient. Now, on further evaluation of the question, you will find that she appears comfortable at rest, but as bilateral wheezes on auscultation. Her peak expiratory flow rate is at 70% of the predicted value. Spirometry confirms the FE, that is forced expiratory volume 1 of 75% of the predicted with a positive bronchodilator response, that is improvement of FEV1 by 15%. Now, on the basis of these, if the pulmonary function tests are provided to you, so if it is less than 60% of the predicted, it is lying in the category of severe asthma, while 60 to 80% of the predicted for moderate asthma, more than 80% is for mild, and more than 80% predicted, but it could be absolutely normal in between the exacerbations, then it is a feature of intermittent asthma. So if I give you some examples based on the scenarios for the differentiation, like in case of severe asthma, there will always be a provision of the FEV1, that is 55%, which is less than 60% of the predicted values. In case of moderate, the features will be provided like nighttime awakenings twice a week, uses their rescue inhalers daily, lung function shows the FEV1 of 70%. In case of mild, there will be symptoms of 3 times a week, occasional nighttime awakening, and need their inhalers a few times a week but not daily. So these are the examples. I mean, how to conclude to the category of the asthma the patient is suffering from. On examination, she appears comfortable at rest but has a bilateral wheeze on the auscultation. Peak expiratory flow rate is at 70% with the of the predicted value. Spirometry confirms FEV1 of 75% of the predicted. So the patient lying in the category of moderate persistent asthma. So this thing you came to know from the language of the question itself. Now is the time to answer this question. Which of the following is the most appropriate initial pharmacological management for the patient? That means they are asking about the drug management for this patient. So let us talk about the management of the asthma. The management can be divided into two. First is the management of the acute or exacerbation or the acute episodes of the asthma, and the other one is the maintenance therapy of the asthma based on the categories. Now, the management of the acute asthma is the short acting beta 2 agonist. As you know, the examples are salbutamol, terbutaline. The mechanism is rapid bronchodilation by stimulating the beta 2 receptors in the airway smooth muscles, as you already know. And these are the first line treatment for acute asthma exacerbation. The other one is anticholinergics. Examples are ipratropium bromide. And the mechanism is that it blocks muscarinic receptors, thereby reducing bronchoconstriction and mucus secretion. As far as indication is concerned, so it could be considered as a adjunct therapy in moderate to severe exacerbation, especially when it is combined with the short-acting beta-2 agonist. Systemic corticosteroids, as you know, already are aware of the examples like prednisolone, methylprednisolone, hydrocortisone, and the mechanism is that it reduces the airway inflammation, edema, and hyperresponsiveness. So it is used for moderate to severe exacerbation, or if the symptoms are not controlled with inhaled therapies. Like first you start with the short acting beta 2 agonist. If it is refractory, then you switch to the systemic corticosteroids. Now it can be given oral or intravenous depending upon the severity. Now, oxygen therapy is always required when the SpO2 dips less than 92% in order to maintain the adequate oxygenation. And magnesium sulfate, the indication is it is used in severe refractory exacerbation that do not respond to initial bronchodilator therapy. As you know, the mechanism of is that it acts as a bronchodilator by inhibiting the calcium mediated smooth muscle contraction. So this is the management of acute. That means it is the rescue management of the asthma from the exacerbations. Now coming on to the long term or the maintenance management of the asthma, which is based upon the global initiative for asthma, that is GINA guidelines. So long term controlled medications are used to prevent the symptoms. It is used to reduce the exacerbation and improve the lung function. The treatment is adjusted according to the severity of the asthma. So based on the category, the first one is for the intermittent asthma. As you know that as needed, short acting beta 2 agonists are required. For mild persistent asthma, low dose inhaled corticosteroids, that means inhalational corticosteroids, are the first line controller therapy, and you are aware of the examples like budesonide, fluticasone, or beclomethasone. Alternatives which can be used are the leukotriene receptor antagonist like montelukast. Like in case of aspirin induced asthma, the leukotriene receptor antagonists are indicated. Then comes the category of moderate persistent asthma. Like low dose inhalational corticosteroids are added with the long acting beta 2 agonist. You are aware of the examples like salmeterol, formoterol. An alternative could be a medium dose inhalational corticosteroids along with a leukotriene receptor antagonist. But this is what they particularly ask you. So we are now switching on to adding the another category of drug, that is long acting beta 2 agonist. Now, for a step further, if the patient is suffering from severe persistent asthma, then these low dose of inhalational corticosteroids are not going to work. So what you need is the medium to high dose of inhalational corticosteroids along with the long acting beta 2 agonist. Leukotriene receptor antagonist like montelukast or theophylline can also be considered, but here you have to increase the dose of the inhalational corticosteroids. And finally, for very severe or refractory asthma, you have to go for high dose of inhalational corticosteroids along with the long acting beta 2 agonist. Also, consider a biologic therapy which is based on the phenotype. Like for allergic asthma, consider omalizumab. For eosinophilic asthma, mepolizumab or reslizumab. or for severe eosinophilic asthma, dupilumab. So we have learned about the identification of the type of the asthma. We have learned about the management of the asthma. Now we can easily answer the question which was asked, that which of the following is the most appropriate initial pharmacological management for this patient's asthma. Now if you go with the option continue as needed use of short acting beta 2 agonist, it is reserved for the rescue management, so it is not the answer. Now initiate low dose inhalational corticosteroid monotherapy and continue as needed short acting beta 2 agonist is the management protocol for the mild persistent asthma, so this is also ruled out. Next is initiate a combination of a low dose inhalational corticosteroids and a long acting beta 2 agonist. This is the correct answer for the category of moderately persistent asthma from which the patient is suffering from. And finally, start oral corticosteroid therapy and discontinue inhalational medications is not obviously the answer for this question. So hope you have understood this very important topic, and you'd be able to mark every answer correctly related to this particular the question, that is identifying the type of asthma and what is the management protocol. All the best for your future examinations. In order not to miss any update, please join our Telegram group. The link is provided in the description.